So one of the controversies, that has continuously arisen over the course of time is the role of autologous stem cell transplant in multiple myeloma. I think that the studies to date continue to support a role for frontline stem cell transplant for those patients who are eligible. But as we continue to improve therapy in multiple myeloma, the question obviously needs to be, continually readdressed. I think it remains to be seen, what the role of autologous stem cell transplant will be 5 years from now and 10 years from now. But I do suspect that the majority of us feel that at some point in the not too distant future, we likely will no longer be doing it. I think another important area that we need to address is this issue of continuous therapy in multiple myeloma versus therapy of a defined duration. I think that it's very clear that with existing treatment, so in other words, a triplet or a quadruplet for induction, with or without transplant consolidation, followed by lenalidomide maintenance therapy until disease progression, is the current best standard of care. So continuous therapy currently is the best treatment strategy for patients. However, when we start thinking about CAR T cell therapy and the potential expense associated with that, but not only that, but the impressive depth of response that we're seeing with these products, when we see the plasma cell depletion that occurs with CAR T cell therapy or with other BCMA targeted therapies like bispecific antibodies, and again, with regards to the bispecific antibodies, looking at cost, can we really afford, both from a safety perspective as well as a financial perspective, to continuously treat these patients as these new therapies get moved earlier and earlier into the treatment continuum? And I think that that will be, addressed in future studies.